Good evening to all. I'm Sajan Yes. Since 8 years, I am working in Parliament as a nurse. So today, I would like to introduce not a new topic, but an important topic in palliative care, ostomy. What do you mean by an ostomy? Actually, our human body having so many naturally orifices are there for meeting the need of or as a part of the body mechanism. Our body need to get something from outside, and after the mechanism, as a part of that, some items need to excrete from the body to outside to the environment. So normally for that need on orifices, some orifices are there, but in some cases the natural orifices cannot fulfill the need because due to some disease condition. That time, artificially or by surgically, we making an opening that is actually calling as a ostomy. So ostomy we can tell as a mainly permanent basis and temporary basis we actually doing the ostomies. Temporary basis means due to any disease condition, one surgical procedure is needed for a part of the organ. So for that organ or that area needs some rest for some time period. So for that natural orifices pathway, we will divert to another as like on ostomy will make and divert it. After the time period of rest, we again reconstruct the normal pathway. But permanent ostomy means in some disease condition, fixedly or permanently we removing the organ part or completely that organ. So normal orifices, that pathway we cannot use. In that situation, we surgically we making for a permanent basis making some ostomies. Mainly two types of ostomies are there: input ostomy and the output ostomy. Input ostomy means as like the word meaning only, so from the environment to the body as a part of the body mechanism, something need to get. Example, tracheostomy, gastrostomy, feeding ileostomy. These are all the example for the input ostomy. But in output ostomy means from the body, something need to excrete out to the environment. So for that example, colostomy, urostomy, and the ileostomy. So here two pictures are there. First one, tracheostomy. It's an example for the input ostomy, and second one, the colostomy, is an example for the output ostomy. So actually, what do you mean by colostomy? Colostomy means normally, as I told, normally by rectum on human excreting out the fecal matter or flatus is coming through the rectum. But in some disease condition, the normally the rectal route is inappropriate or rectally the evacuation cannot occur. In that condition, surgically we making an opening on abdominal wall, and the internal that large intestine part we will take it out through the abdominal wall and fix it on the abdominal wall, and we will make as a opening as like the rectum. Through this ostomy, the fecal matter or the flatus is coming outside as the colostomy. So simply anatomically just I am telling, our large intestine is a hollow organ only, around 1.5 meter length. According to the anatomical part, the ascending colon, transverse colon, descending colon, and the sigmoid colon. According to the part where the ostomy we making, according to the part, the name vary as like ascending colostomy, transverse colostomy, descending colostomy, and the sigmoid colostomy. So actually, this one is the picture of the colostomy. Normal stoma looks like this only. And the last picture is on appliance. Can anybody tell that appliance name? On stomal region, we will making this, we will using this appliance for collecting the fecal matter. Can anybody tell the name? Okay, this one is the colostomy bag. So actually this applies or this colostomy bag, mainly two types of colostomy bags are there. First one is the one-piece method and the second one is the two-piece method. One-piece method means along with the colostomy bag, the waste plate is there. That sticky, that waste plate is along with the bag. That is the one-piece method. If we need to remove the bag means all with the adhesive part of along with that, the bag we need to remove from the ostomy side. Second one is the two-piece method. Two-piece method means bag separate and faceplate is separate. So whenever we need to change the bag, the separate bag independently we can remove from the faceplate. Whenever the faceplate needed to remove from the ostomy side, at that time only we needed to remove. Otherwise, we can reuse the bag on that same faceplate. So normally the colostomy bag we will get in one size. According to the stomal size of the patient, we need to mark it and we need to cut the hole. We will make the hole. Then only we can use the colostomy bag for the stoma. First of all, along with the bag, we will get one measuring gauge. First picture is showing us a measuring gauge only. This measuring gauge have so many circles are there. Every circle having independent values as like millimeter diameter measurement is there for every circle. So we need to select appropriate circle for the stoma. We need to place it on the stoma. That circle don't be too tight and don't be too loose. Appropriate proper size we need to select. Then we need to mark it on the base plate of the colostomy bag. Around 4 millimeter bigger than the actual stomal from the gauge, measuring gauge, we need to mark it. Then by using circular curved scissors we will get. By use that curved scissor we can cut easily and we will make according to the stomal size. We need to cut the hole on the faceplate of the colostomy bag. Then only we can keep this bag on the stoma. One thing we need to keep in mind, this while preparing the hole or according to the size, the hole never it's too tight means it will disturb the stoma. Too exposing the peristomal area means it will cause the leaking of the fecal matter or any other items. It will keep in touch with the peristomal area. So the hole will be very appropriate by using the measuring gauge. Maximum 4 millimeter bigger than the actual size of the stoma only we need to select for cutting the faceplate of the colostomy bag. Then while we seeing the stoma of a patient, some assessment we need to do. First one is the stomal edema. If we suppose we seeing one stoma with edematous means soon after the surgery, the stomal edema is normal only, because around 6 weeks time needed to become one stoma in a normal stage. So gradually the edema will decrease. Soon after the surgery, the edema will be normally. We need to keep it in mind. Then second one is the stomal prolapse or the bleeding. So this stomal prolapse mainly happening means if the stoma is very much large stoma means it will leads to the stomal prolapse. Then abdominal pressure getting activity means if the patient is lifting weight by using that side hand means also it will cause the prolapsing of the stoma. Then if the patient having any cough, sneeze, or if the any nearby site, any tumor is anything is having means it will cause the abdominal pressure. So due to the abdominal pressure, this stomal prolapse will happen. So mild prolapse means we can reinsert the prolapsed stoma, but moderate to severe prolapse means need to get an opinion from the surgery opinion we need to take, and according to that, the management is needed. Then bleeding. In some cases, any accidental injury, or already if the patient is taking any NSAIDs drugs, like that time also, this type of bleeding chance is there. So this one is the parastomal hernia. Parastomal means around the stomal region is the parastomal region. So in some cases, inside the abdominal wall, along surrounding the stomal internal abdominal wall, there is the colon part is sticky with the along with the stomal surrounding area. So at that region, some maybe the bowel content it will collected as like a pocket formation, or otherwise surrounding the area, the abdominal muscles are very weak only. Already the continuity of the muscle loose due to the surgery. So in surrounding area, the inside part it will herniated. There is a chance is there. So this parastomal hernia it will occur. It's happening means also as like the hernia repair as like same mesh, by using mesh we can repair the hernia. But there is a chance for if the parastomal hernia is occurring means also we can choose another side for the colostomy. But there is a chance for the repeated chance for the hernia. It's a complication only. Then this one is the retraction. Retraction means stomal retraction. Normally the stoma is a protruded stage only. Little bit protruded only, but here this everything is a retracted state only. So here one pulling effect is happening inside the colon. Due to the pulling effect, according to the bowel movement, this pulling effect, and due to that only the stoma it will be very introverted or retracted, that type of stage. But here one thing you can see, normal stoma means the faceplate, normal faceplate only we can use for fixing the colostomy bag surrounding the stoma. But here, this retracted state, both sides, there is one gap is there. So here we, while if we using normal colostomy bag means normal, that is face plate means in between one space will be occur. Due to the space, the parastomal area it will get contact with the fecal matter or the waste material coming from the stoma. So here one convex type of face plate having colostomy bag is there, special bag. That type of convex type of face plate with colostomy bag, that type of bag only we can use in this retracted type of colostomy. So around studies telling around 14% of colostomy cases, this retraction is happening. If there is in our assessment this retraction happening means we can use that modified convex type of faceplate colostomy bag for collecting the fecal matter. Then this one is the peristomal reaction. Means peristomal area means surrounding area of the stoma. Here already I told, while we using the colostomy bag, the size will be not too loose and too tight. If too loose means the chance for getting contact with the peristomal region with the fecal matter and the waste material. So if the continuous keep in touch with the fecal matter on the peristomal area means it will cause the peristomal reaction. So for avoiding the peristomal reaction, we need to give good skin hygiene, or otherwise the peristomal reaction already we notice means also we need to do the management. So here as a part of the skin care, proper skin care, wash the peristomal region with soap and water. After cleaning, we need to keep dry for a few times. Then use correct size of bag. Repeatedly I am telling, not too tight and too loose. According to the proper size as per the guidance, that measuring gauge only, we need to select the proper size of the bag, then we can fix. Then after fixing the bag, maximum 3/4, half portion maximum, maybe it's maximum 3/4 portion of the bag is filling with fecal matter also, we need to empty. Otherwise, it will overflow and keep in touch with the peristomal region. It will cause the excoriation. So that thing is important. Then for cleaning, cotton clothes only can use, because cotton material only skin friendly. So that cotton clothes can use for cleaning. Then if any skin excoriation we noticing in our assessment time means, we can use karaya powder. Karaya powder. So this one is the naturally getting karaya plant and karaya tree. While cutting time, that oozing thing only we will make it as a dry and powder form. Commercially, we can get like this only, karaya powder. This karaya powder, this karaya powder, we can mix it in the egg white. Then it's a in home setting also we can do this karaya powder, mix it in the egg white. Then we can apply the mixed karaya powder in the egg white on the peristomal region. Just give some time for drying. After complete drying, that area, it will looks like a film coating. Then on the coating only we can fix the colostomy bag, that base plate we can fix. So there is a we will avoiding the chance to keep in touch with excoriated area with the base plate. In between on as like film coating, this karai with egg mix, it will be there. Then in along while we purchasing time, the along with the colostomy bag, some barrier cream also we will get. That thing also we can use for avoiding the leakage of any fecal matter from the stoma, and it will avoid the touching with the peristomal region. Then zinc oxide also can use. Then if the any foul smell is there means also we need to educate the patient, don't use or avoid the use of any powder or any cream or any deodorant like that items also they cannot use. They need to avoid the usage because it will irritate the peristomal and the stomal region also. Then, if one patient with the colostomy, normally, as we telling about the diet means, any food items having any gas forming food means they need to control. Then chili and spicy type of food also they need to avoid or they need to control, because it will disturb the bowel pattern and it will cause the stomal irritation also. So that thing we need to educate the patient. Then control onion, cabbage, that like gas forming or smell type food they need to avoid. Garlic and meat items also, or otherwise they need to control. Then same cooking oil only they need to use for cooking. If the patient is have the practice food items cooking in the coconut oil means, they need to continue the practice in coconut oil, same cooking oil only they need to continue for cooking in colostomy period also. Otherwise it will cause the diarrhea. Maybe the loose stool is happening means also there is no sphincter control in the stomal region. In rectum means there is a sphincter control is there, so they can even they can control. But here there is no control. Whenever the bowel opening means also the fecal matter it will come out into the colostomy bag. So continuously the diarrhea means also it will disturb the patient. So they need to use same cooking oil for avoiding the diarrhea. Then as like same diarrhea, the constipation also very much important. Constipation also it will disturb for the patient only. So use high fiber diet and use fluid intake also. More fluid intake they need to take in their diet. They need to increase the fiber and the fluid intake also. Then while traveling time, the stomal, if the patient is in a public transportation system means also nearby persons or accidentally any injury is there is a chance is there while hitting on the stomal region. So they need to protect their own stoma with a purse or a handbag. They can use it. Then extra colostomy bag also they can carry during the journey. because in between their food pattern will vary. According to the food pattern variation, the diarrhea maybe their chance is there, or otherwise the bowel volume it's more, it's maybe there is a chance is there. So they need to carry extra bags also during the journey. Then clothing. For a clothing, there is a no restriction. Whatever may be the clothing, the patient is comfortable, they can use. But the clothing, there is a one thing they need to keep in mind: don't disturb the stomal site. At the, as like whichever dress they is comfortable, they can use. Then sexual life, they need to get proper support, both the patient and their partner, because they have the right to get the love and compassion, and they need to give the love and compassion. So proper support we need to provide. Then advices, any advices needed means also we can provide. Then encouragement and counseling also. Any counseling for the patient and the partner is needed means also we can suggest and we can provide. Then already I told two-piece method of colostomy bag is patient using means also patient can alternatively they can change the bag while keeping the faceplate on the same area. Bag only independently they can change. They can wash it, clean it, and they can reuse the bag up to it getting any hole or any tear. So at that time, use correct size of bag only. Then empty the bag maximum 3/4 portion. It's safe. Half portion of bag is filling with fecal matter also. They need to empty. Otherwise, it will cause the overflow, and there is a chance for getting contact with the peristomal region with this same waste material. So while washing the bag, use soap and water for washing the bag. Then if any foul smell is feeling for the patient, means they can put small charcoal pieces inside the bag. It can prevent the foul smell inside the bag. Then after washing with soap and water, we can dry the bag under the shadow only. Direct sunlight, under the direct sunlight, don't dry the bag because it will cause the cracks on the bag material. Then rough brushing or stone washing also can promote. They need to avoid this stone washing and hard brushing on the bag.
Sajan, please continue. They will show it later.
So here one case scenario is there. Can anybody just read it?
Can any of the participants please read out this case?
Can I? Hello.
Yes, please. Yes, please.
Mr. T, 45 years, was diagnosed with carcinoma rectum and had undergone sigmoid colostomy 3 months ago. He has been using disposable colostomy bag for bowel emptying. He is a management executive and finds it very difficult to manage it. What option can you advise him as a palliative doctor or nurse? This is the question.
You can put your answers in chat box. Any suggestions you can tell me, you can put it in the chat box also. I think already you gone through this case. Then what option can you advise him as a palliative care nurse or doctor? Any idea?
Please suggest something. So if you have seen these kind of patients in your settings, if he is asking you to, I am very difficult to manage this. So what are the other options you can suggest for these patients? We need to continue the care now. So please suggest something. Okay, training and counseling. Then what else?
As a management basis, anything else you can suggest? So actually, in this case, according already in anatomical, in the third slide already I told, according to the part of the colon, the wherever the colostomy is making, according to that, the name will vary. Here, this one is the sigmoid colostomy. So sigmoid colostomy, for that we can suggest this colostomy irrigation. It's a management we can suggest for this type of colostomy. So what is the colostomy irrigation? Actually, the irrigation means simply we can tell is a flushing out or washing out the total colon at a single time as the colostomy irrigation. Actually, why we need to do this management for the sigmoid colostomy? First one is to establish the regular bowel habit. Normally, a human means every day one bowel habit is there. Some patient they're having once a daily, or some patient having twice a daily, having the bowel habit. That's a habitual only. But here there is a no sphincter control in the stoma, but we can make a bowel habit for the internally the total colon. We can make on habit. So at a permanent fixed time, in 1 day, 1 time, we just flushing out or washing out total colon by this procedure, then it will help for the making of the habitual bowel habit. We can establish. Then total gas, mucus, and fecal matter, everything at a time we can completely wash out or clean out the total colon. Then totally we cleaning the colon. So in between the oozing out or in between the coming of fecal matter or any mucus, that thing. So there is in between, there is no oozing. So there is no chance for getting contact with the peristomal region with this waste material. So we can prevent the skin excoriation also. Then here mainly we using the solution plain lukewarm water only we using for giving the colostomy irrigation. Here the sigmoid colostomy, already I told, for the sigmoid colostomy only this colostomy irrigation we can do. Why? Because in ascending to that transverse in between the distance or transverse that area, there is on fecal matters consistency will be in the liquid or mushy type of fecal matter only. From there, the colon need to absorb the elements, minerals, and the water content also. Colon need to absorb it. So in that type of transverse colostomy or ascending colostomy, in between, if we doing the colostomy irrigation, means it will cause the profused fluid lossage from the body, and the mineral and element also lossage is happening. So in sigmoid colon only, the proper fecal matter consistency will get on the sigmoid area only. So in this sigmoid colostomy, if we giving the colostomy irrigation, means it will helpful and it will not cause any fluid lossage or mineral or any electrolyte imbalance also not at all happening for the person. So first one, some instructions we need to give for the patient and the family. First one, if you're starting the irrigation, means that irrigation they need to continue for a lifelong. In totally in their life, they need to continue this irrigation in their daily routine. Then habitual formation, it will form only after the 21 days. We need to explain. Otherwise, soon after just starting the colostomy irrigation, they will expect this habitual formation. So we need to convey it as around 21 days is needed for getting the habitual formation for the colon. Then daily in fixed time only they need to irrigate. Morning, if they are practicing, means every day morning they need to irrigate in a fixed time. So actually this picture just I'm showing the parts of the appliances. First one is the that already I told, lukewarm water only be using. That water collecting bag only, first picture. Along with the bag on tube is there. In tip of the bag on cone shape of on tip is there. That tip only we will insert into the stoma. Then in between for adjusting on clamp is there, or that rolling clamp is there. According to the adjusting the rolling clamp only, we are regulating the fluid from the bag to the stoma. Then one sleeve is there. Sleeve means sleeve, that end, one end we can keep it in the inside the closet. That starting initial end of the sleeve having one belt also. By using the belt, we can place this sleeve on the stoma. Then after filling the lukewarm water on the collection bag, by regulating the adjuster, by inserting the cone tip of the tube into the stoma, then we can freely open. Then this lukewarm water, it will enter into the colon and fully wash it out, and it will come out through the sleeve and into the closet. So while we keeping the irrigation bag or that collecting bag, while hanging time, don't be fix it too high from the head level. Just on the head level. If the patient is sitting position, means according to the head level or just above the head level only, they need to keep the irrigation bag or the water collection bag. If suppose we keeping this irrigation bag in too high, means gravitational force also it will too high. So the according to the gravitational force is high, means it will cause the colicky pain and abdominal cramps also will feel for the patient. So the height of the irrigation bag fixing, we need to keep it in mind, and we need to educate the patient for practicing. Yes. So I think already you've seen colostomy video, everything you've seen. So we completed the colostomy as an example for the output ostomy. So now we moving to the example for the input ostomy, tracheostomy. Tracheostomy means normally the one person by the through the nostril only patient is inhaling and exhaling, but due to some disease condition, the normal airway is not possible for the patient. That condition on trachea only artificially we making one opening to which one tube is inserted to establish and maintain a patent airway for the patient. That's the tracheostomy. So here the tracheostomy, actually first picture is showing us a steel type only. Second one is a Portex type. Then steel type or Portex type, here actually three parts are there. First one, outer cannula or outer tube, inner cannula or inner tube, and the obturator. Now I have another question. Comparatively, which cannula or which tube is having more length? Inner cannula or outer cannula, which one having the more length? Can anybody tell?
Outer cannula.
Outer cannula.
Any other answers? Inner cannula. Okay, one answer I got as inner cannula. So here inner cannula is have more length than the outer cannula. Why? Because while on patient is in tracheostomy means this tracheostomy tube, outer cannula will be there on the tracheostomy side with support of ribbon or with support of a tie around the neck. In between the inner cannula only we are removing and cleaning and we replacing on the outer cannula. So here the inner cannula having more length means if suppose any mucus or anything secretion is blocking the outer cannula, while we reinserting and inserting time, this inner cannula is if having more length means it will push out or it will just open the blocked part of the outer cannula. So here the inner cannula is having more length than the outer cannula. Then this obturator we actually be using as a guidance only while doing the tracheostomy time. While inserting the tracheostomy tube on the stomal at time, this obturator act as a guide for insertion. So already I told inner tube only in between we are removing and cleaning. For cleaning, we can train the patient for inserting and reinserting, washing, everything can do by the patient only the inner tube. So we need to train the patient to sit in front of a mirror. With the help of the mirror, they can remove the inner tube. Then inner tube thoroughly clean under the running water. Cleaning of the tube inside and outside of the tube thoroughly we need to they can clean under the running water. Then after cleaning in boiling water for 5 to 10 minutes they can boil it and they can sterilize the inner tube. After that they can clean with the normal saline. After the cleaning procedure need to ensure completely the inner tube having at least a droplet of water content is also not there. They need to ensure. After the complete drying only, they can reinsert or reuse the inner tube in the outer tube. Then outer tube not to remove by the patient, only the inner tube they can remove and clean. Then they can clean the outer tube part, only the outer part, that face area of the outer tube only they can clean by using saline soaked gauze thoroughly. Then changing the outer tube tie means also patient no need to change by the patient, only the caregiver or with the assistance only can change the tie from the outer tube around the neck region. Then it is applied to fix the tube in a position only by using this tie. Then if we suppose need to change the dirty tie or the ribbon around the neck region, before removing, we need to fix a new one. In proper position, we need to fix it. We need to ensure, then only we can remove the old tie. Then after tying with the new tie around the neck region, we need to keep 1 finger gap in between the tie and the neck. That gap we need to maintain. If too tight and too loose means, too tight means it will irritate the stomach and it will cause the continuous cough and the stomal irritation also. Then too loose means it will chance for the tube will come out. If the patient is sneezing or coughing time, that time the tube will come out. So that 1 finger gap we need to maintain in between the tie and the neck. Then attempt of changing the tie by the patient, we need to educate why they don't want to remove the tie by self. That self attempt they can't do. Only the inner tube only can remove and clean by the patient. Then as like same only, here also one stoma is there. So proper skin care is needed. This surrounding the tracheostomy tube, the skin clean very thoroughly with saline soaked gauze. Then keep the skin around the tracheostomy tube clean and very dry. But in between the area is very chance for sweating, and in between the mucus is getting contact with the peristomal region. So after cleaning and after drying the area, Vaseline gauze is helpful for preventing the excoriation. That by using the gauze, we can just around the stomal region, we can cover it under the faceplate of the outer tube. Then if the patient needed to get the suction, means suctioning can do maximum 10 seconds, 5 to 10 seconds time only can suck at a time. So very gently, not more than 5 to 10 seconds suck at a time, because it will cause the hypoxia. We need to prevent the hypoxia chances for the patient. So that time we need to maintain. Then as a part of the humidification, while on after the cleaning and after maintenance of the tracheostomy tube in position, wet sterile gauze on the top of the tracheostomy tube they can put, because it will help some humidified effect of air entry into the trachea. So inhaling the time in air, it will filter the dust or any flies entry, it will prevent. So here in tracheostomy, if one patient is in tracheostomy, means normally the patient can't speak, but even after starting the proper speech therapy, means while patient taught how to talk, take a deep breath and then close the tracheostomy tube with a finger, then speak 1 or 2 words. Gradually they can increase the words numbers, and again take a deep breath and then do likewise. That practice they need to maintain. Gradually they can speak even if the patient is having the tracheostomy means also.
So because after the theory, so was able to put some videos so that you can able to understand more. So even then, if you have any doubts, please ask him. Otherwise, we can move on to the case presentation part. So I think we can move on to the case presentation part now. In between, if you have any doubts, please put it in the chat box so that we can able to answer you later. So Sister Stella will be presenting a patient story today. Stella, sister.
Do we have any volunteers to read out the case?
Yeah, so I think one of the participant can read it out. Anybody?
You are muted. You put your slide. Oh. We are not able to hear you. Sister Emma, if you are trying to communicate, we are not able to hear you. Shiva ma'am, in best interest of time, is it okay if I read out the case and then?
Hello?
Yes, Shiva ma'am, you are audible.
Yeah, yeah. So, what about the participants?
One participant had raised hand, but now I think.
No, I'll
Okay.
read out if no one is here.
Josh? Yeah, yes, Rema, please.
Patient details: 56-year-old female, colon cancer with metastasis. Presenting complaints: patient came alone in the palliative care center. Patient was sad and anxious. History of illness: worked as a casual laborer in local church. When she started having abdominal pain and passing stools that had blood, she went to see the doctor, who ordered some tests, including colonoscopy. The results revealed that she had a tumor of colon. Surgery was done, and ileostomy was done. Started on chemotherapy, 12 cycles completed. On examination, she was short hair, eyes, mouth, tongue, no abnormalities, ear, neck, chest, and hand, no abnormalities found. Wound was clean, abdomen had a stoma, colostomy was there, stoma, ileostomy, loop highly active, skin around the stoma was normal, clean and pink. On abdominal palpation, there was no swelling. Pain was there, left iliac fossa radiating to the back, thighs are normal, leg, back, anal region is patent. Some stool noted. Present symptom: pain moderate, numerous rating scale 5 on 10. Nausea, vomiting was a complaint. Loss of appetite was there. Treatment and significant investigation: pain management was planned, psychological support was also planned. Psychological aspect: Jane, not her real name, is a widow. Patient is a widow, mother of three, living in an informal settlement, casual laborer. Two of her children work as a casual laborer too. Last child is in school. Firstborn son lives alone, sometimes gets involved in criminal activities, make him get arrested by police. After cancer diagnosis, Jane was laid off from work, and all support was removed, including insurance support. No one offered for food, treatment, and other needs. Parents and other family member live up live up country. I don't mean what that. Medication: after taking the history and looking up presenting complaints, Jane was put on dihydrocodone 30 milligrams after in the duration of 8 hours, metoclopramide 5 mg thrice daily, dexamethasone 1 mg twice daily, Senecot 10 mg, review after 1 week. There are home visit scheduled for the psychological support to the family. She was also encouraged to join the support group at hospice. Main concern: pain, colostomy bag, chemotherapy. How to get chemotherapy? This wasn't on. Mother of three, widowed, diagnosed with colon cancer, underwent surgery. with the colostomy. She's on hospice care for pain and symptomatic management. Pain management, psychological support, social support is the points to be discussed.
Thank you, Hema, for reading out the patient story. So anyway, we need more clarification for this patient story. Is Teles there?
No, ma'am.
No.
No.
So her main discussion point was pain management, psychological support, social support. So we would like to know about the pain core and what is the pain status now. That all things we would like to know from her. So any suggestion? So this patient is on dihydrocodone, which is a strong opioid. So it is not available in India. But that drug is for moderate to severe pain. It's a strong opioid. So any other concerns? So today we learned about colostomy care, tracheostomy care. So this patient is having ileostomy. What are the problems can occur that after ileostomy? What is the possible complication that can occur on a ileostomy patient? What do you think? One of the most common complications for an ileostomy patient. Please unmute yourself and talk or put your answers in the chat box. So as Sajan was discussed earlier, whenever the bowel is moved through the opening, the fecal matters will come out. This patient is having ileostomy. So what kind of fecal matters will come out through ileostomy? That all things you have to think. So one of you said dehydration. Very good. Then any other points? So we all know it's please put something or you can unmute yourself and talk. I'm sure you have seen a lot of patients like this, colostomy, ileostomy, tracheostomy patients. So you might have a lot of questions. Thick liquid comes out through ileostomy. Okay. Any other answers? So infection, what kind of infections you expect? Jeba? Any other points? So now we got 3 points. Dehydration, thick liquid comes out from the ileostomy infection, wound ulcer proliferative infection. Where you expect the wound ulcer proliferative infection? If there is a fungating wound, like a cancer wound there, you will expect the proliferative growth. But this is a colostomy. These kind of patients will develop skin excoriation easily. Okay, so why these kind of patients can develop skin excoriation? Sometimes Candida infections there, but most often the patients will develop skin excoriation, peristomal skin excoriation. So this is one of the most common complication with ileostomy patients, and also dehydration. So because before moving into the large intestine, moving the fecal matter to the large intestine, that all fecal matters will come out, no? So the major function of large intestine is to absorb salt and water. So before that, the fecal matter will come out, no? So that time the patients might have developed dehydration also. But usually the peristomal skin excoriation will be there. So because the small intestine, there are a lot of vitamins and minerals because of the concentrated things that will leak into the normal skin, that patients will develop peristomal skin reaction. So that is why if the patient is having ileostomy, you have to give a special attention on that area, because if the stomal size is just correct size, not big, not a small. So that kind of size should be there. Otherwise, the fecal matters will touch the normal skin and develop peristomal skin excoriation. So this is the most common problem. Any other points you want to discuss? Again, psychological support. Again, we all know that. So when the bowel is moved, the fecal matters will come out. No, so normally this not was happened in a normal person, but these kind of patients have a lot of problems because of this. When the fecal matters will come out, foul smell will be there. This will be affecting the patient family a lot. So definitely these patients need a good psychological support and counseling, and also social support. So she was saying about colostomy kit, lack of availability of the colostomy bag. So maybe because the financial constraints will be there, so we will try to find out the money for getting colostomy bag, and you can connect with the local community people, like palliative. If there is any NGO nearby there, you can connect with them, and so that they can able to provide some give some kind of help. So again, she has 3 children and widow. A lot of problems. No, she definitely she will be worried about her children, because nobody is there after her. Nobody is there. So we need. So I would like to know about the caregivers part and all. So who is the primary caregiver? That all things we will. I would like to know from Stella, sister. So unfortunately, she is not there. Anyway, so any other points you want to discuss, or any comments? Sajan, do you want to add anything?
Nothing, ma'am.
Okay.
Almost everything.
Okay. Any points? Anybody? We have 5 minutes more. So anybody wants to add anything or any clarification there, please ask. Definitely, you can think about the colostomy irrigation for a sigmoid colostomy. If the patient is having sigmoid colostomy, you can think about the colostomy irrigation also. You have to tell them about the colostomy irrigation, the importance of colostomy irrigation, and also have to tell the important point. If they are agreed to use the colostomy irrigation thing, so they have to be continue as a lifelong. So that is, they might be thinking like, okay, one time, okay. If I buy colostomy irrigation, okay, one day or at a time, maybe if I irrigate one day, maybe 1 week, it will be all right. That might be, that kind of thinking will be there. Always you have to talk to them and make them understand well about colostomy irrigation. If they are agree, you have to tell them it's a lifelong procedure. They have to do it in a correct the same day, same time. Then only the habit formation will be there. Okay. So these are the important points you have to tell the patient and family about. So always you have to think about the sexual part also. If they have I have seen many patients like that. If they have if their partner have a colostomy or a ileostomy there, they will not be, they usually afraid to do the sexual intercourse. These all will be affecting the patient emotionally and spiritually too. So once you develop the good rapport with them, so definitely you have to ask them about the sexual history and all. If they have any problem is inside, if they have any misunderstanding or misconception, there you can try to manage. You have to make them understand that. So you have to convince them. Okay, so. These all points I want to say. If you don't have any doubts, we can wind up. So we learned many things today: colostomy care, colostomy irrigation, tracheostomy care. So Sajan was taking clearly about these three things: colostomy care, colostomy irrigation, and tracheostomy care. So thank you, Mr. Sajan, for the wonderful presentation. Thank you, Sister Hema, for reading out the patient story. Thank you, everyone. Thank you. Thank you for your contribution. Thank you.
Thank you, Sajan, for your wonderful presentation. Thank you, Shiba ma'am. Thank you, everyone, for joining us. This is Anup, along with Sajan and Shiba ma'am, signing off from Tipsarco. Bye.